both lectures because I think they will talk the similar things. Professor Thapa, you can present your lecture, please.
Thank you, Officer. Well, let me share my slide. And it was wonderful listening to Eduardo. And while listening to him, I was just reminded of Professor Alberto Roten. And he used to tell the same type of story, linking everything to what all he would say. Thank you once again for this opportunity. And I will be talking about a very basic but very crucial topic, craniometric points in the surface anatomy. I have nothing commercial to disclose in this presentation, and whatever remark I would make to some of the commercial products would be just for education and sharing experiences. Well, we all know that the navigation had actually started with the use of the ocean explorer using the polar star as well as the sun as the coordinates using the 16 devices. And now we have GPS system in our mobile phone which uses the triangulation method to localize any part of the Earth. In the brain, we have the similar technology using the navigation system where we can even track the fiber tracks these days on the real-time image, on the images of the images of the patient, on the patient's head as we are operating on the patient. Well, this may be of very much help, but then one of my medical students, while we were using navigation system, did ask me, then when we have all these advances, why we're still using craniometric points? Well, the answer to it is that we need to make a plan, we need to position the patient, and then we have to fix the patient and attach it to the navigation system. So before we come up to navigation system, we need to have everything decided on the base of the craniometric points. So craniometry is basically a scientific study to study the sizes, shape, and the proportion of the human skull. And craniometric points are those crucial landmarks over the cranium which can be used to identify or measure these craniometric measurements. Now, the criteria of using these craniometric points have to be easily localizable, and they have to be consistent so that everyone who is looking onto the patient's skull can identify these craniometric points very easily. And the uses are definitely for surgical planning, neuronavigation, and real-time guidance as we are operating on the patient's head. And of course, in some cases, when we are using along with the radiology, we can even use it for a diagnosis, which we'll just touch upon in the end of the slides. So we have already discussed about the craniometry, but it started with the methods of physical anthropology and phrenology in the late 19th and the early 20th century, where the earlier scientists actually merged with the mathematical concepts to make certain primary mechanical tools to navigate to the lesion of interest. So slowly it started with the topography as was devised by Broca's theory of cortical localization, and it later on moves towards the modern day of stereotic techniques. So it has seen the transitions over the period from. So as you all know, it all started with the exploration of the cerebral abscesses, and the early literature are full of way how they would clinically localize the patient's lesion based on the symptomatology, and then they will put it on the patient's head, the exploratory burr holes to find out these abscesses. Well, it will be always very important to quote the name of Pierre Paul Broca, who was supposed to be the pioneer of these studies, a French anatomist and surgeon. And when he reported in 1861, the first study of craniocerebral topographic correlation, it Mahadeva's study, where he had very strategically placed wooden pins through the cranial perforation and then examined their position to the autopsies, that he could actually make an observation which is still true to date. He said that the upper end of the Rolandic sulcus, which we now call as SRP or superior Rolandic point, is between 40 to 50 millimeters behind the bregma, which is so true to the date, as well as a lot of things which he has then said has actually been true. And then he even used this technique to evacuate abscess in 1876. Sadly, 4 years later, he expired. And this is the figure of the brain, which he used to identify the speech area using the Broca-Champiers method. Well, beside this, there have been many scientists, many workers who have, throughout the last century, worked over these craniocerebral relationship. I'm just putting their names and the pictures so that they can be remembered for their contribution. However, one should understand that this particular craniocerebral relationship actually marks the localization of the cerebral gyrates and sulci as according to the craniometric points. And as Dr. Rivas has already told in his presentation, that there can be anatomical function variations even between the two hemispheres. And that's why this found the complete function reliability solely on the craniometric points can be subjected to errors. And that's why one has to be cognizant of this fact. And even the underlying pathology can displace the gyrus and sulci, can even involve it, particularly the intraventricular pathology, which can even dilate the structures. And the recent publications by many authors have actually shown that to the long-standing lesions, the brain starts having because of its plasticity effect, tries to replace the function of that particular involved area, and henceforth all these particular localization done solely on the basis of craniometric points should be supplemented by intraoperative function and neurophysiological testing. So this is a small pitfall I just wanted to notify before we embark on this journey of craniometric points. So when we study a skull, we always study the skull in three planes because it's a 3D structure. So we read on a mid-sagittal plane, we need to understand, but the axial plane is something which we all miss. And that's right, for the standard of for the purpose of standardization, we always take Frankfurt plane, which starts from the inferior orbital margin and goes to the upper margin of the external auditory meters. So this plane, or the Frankfurt plane, is considered to be the mean horizontal plane of the axial plane, and all the perpendicular lines which are drawn vertically are taken perpendicular from this plane. So when we talk of the coronal plane and look at the anterior aspect, the most important craniometric point which we always come across is the nasion, which is the depression which is made by the fusion of the nasal bone and the frontalis bone. And then as you go up is the glabella, and then in the center is the sagittal suture, and the sagittal suture with the junction with the coronal suture forms the bregma. And then we have a frontozygomatic suture point, which is also very important because this is something which is palpable just above the lateral canthus and also actually marks a very crucial craniometric point from the front. When we look at the back in the coronal plane, then it becomes the fusion of the superior sagittal suture with the lambdoid suture, which is the lambda. And when we come 2 to 4 centimeters below, it is the opistocronium. And 2 to 4 centimeters below will be the inion, and then there will be a superior ligament and the asterion at the back. Now, when we look at the sagittal plane from one lateral aspect, the important craniometric point is again frontozygomatic point, and then is the superior temporal line, which is basically the attachment of the superior temporalis muscle, and then below it will be the squamosal suture, which is again another important point, and the pterion. And then when we look at from the up, then we have the frontal, the parietal bossing on either other side, which is also known as irion. And then we have the coronal suture, and then the lambdoid suture, and in the midline is the sagittal suture. So these are the important craniometric points which everyone should know before we embark on this journey. Beside this, there may be other points like glabella, which we've already talked about. Then there can be opistheon. So unlike opistocranion, which is the most posterior protuberance, opistheon is the posterior margin of the foramen magnum, whereas the anterior point of the foramen magnum is known as basion. And then we have nathion, which is the mentis, and then the gonion, which is the tip of the angle between the ramus and the body of the mandible. So pterion is something which we all should be cognizant because this is the posterior part of the fusion of the coronal suture with the H-shaped structure, which is basically a fusion of the frontalis, temporalis, squamous, and the sphenoid bones. And the porion is basically the upper part or the superior upper part of the external auditory meatus, so which is also taken to be one of the craniometric point. So we have already covered about the irion, and the zygon is basically over the zygomatic process, the latermost part, and the gonion. So when we are looking up, these are the important structures which we need to identify. Now, this particular skull, which is basically showing the gyrus and sulci beneath and the bone above, actually shows the relationship of the nasion to the bregma, which is almost 12 to 14 centimeter. And the bregma, again, from the lambda is around 12 to 14 centimeter. And the lambda from the opistocronium is 2 to 4 centimeter. And the opistocronium to the inion is 3 to 4 centimeter. Now, this particular figure also shows the relationship of the squamosal suture line to the sylvan fissure. So you can see the sylvan fissure actually starts anteriorly with the squamosal suture, but then it moves up. And that's why the posterior sylvan point, which is the posterior most tip of the sylvan fissure, basically lies above the squamosal suture, and it is much more closer to the superior temporal line as we see it. And then there's a portion known as the Stephanion, which is basically the intersection between the bregma and the superior temporal line, which actually tells us about an important key point, which I will be discussing in the future slide. And then there is a pre-auricular depression, which is basically the depression which is felt just in front of the tragus, which is a palpable depression, which is also another key craniometric point. Then in the open face, you can see oral, staphion, endomorph, and vision. Well, this is not something which we will be considering more in the skull-based approaches. Now, when we talk of the size of the skull, the length of the skull is identified by the gap between the glabella and the opisthocranion, whereas the width is between the urion and the urion on the other side, and the height is from the bregma to the basion. Similarly, over the face, it is the nasion to the nathion, and the width is taken from the zygon to the other side of the zygon. Now, when we talk of craniometric points, it is important to make three different parameters. One is a circular line, which starts from the nasion and ends into the inion and divided into 4 parts. So the third quarter of the part, which actually gives you an idea of a sylvan fissure when we started from the frontozygomatic suture and then extended to the third quarter of the telehotter line. So the first 2/3 of that line can actually tell you about the sylvan fissure. Now, the other 2 lines which are important for us to understand is the posterior ear line, which comes from the mastoid tip and goes perpendicular to the Frankfurt plane and hits 2 centimeters behind the midpoint of the telehotter lines. Well, that actually makes the point of the superior Rolandic point, or SRP, actually tells you that the central sulcus actually finishes in the mid-sagittal plane at that particular point. And where it hits the sylvan fissure, it is actually a localization for central sulcus. Now, that point where it hits the sylvan fissure can also be made by the condylar line, which starts from the condyle and it goes up. And this line is almost 2.5 centimeters from the pterion. Now, beside this, there is a point known as Chatter's point. Well, this is identified by a 6 centimeter height from the osteomedial orbitomedial line. Now, this line is basically above the posterior sylvan point, and it is basically the area of the angular gyrus where we are nowadays in the area where we are doing an EC-IC bypasses. So, mini craniotomy of 4 centimeter, which is centered over the Chatter point, can actually expose the M2 and M3 segments where you can do an EC-IC bypasses. So when we do a craniometric point analysis, it is always very interesting to note how these sutures and these intersections are lying over the brain. And this particular figure actually shows that the central sulcus at the interhemispheric fissure, that is also known as superior Rolandic point, is almost 5 centimeters behind the bregma. But at the level of the superior temporal line, it is almost 2.5 centimeters behind. So this can also let us know that this is the central sulcus is actually moving behind, and that's why it is much more posterior to the bregma as when compared to the lateral aspect. And similarly, when we see the relationship of the taller heightened line, it can also be associated with this particular model. Now, Ribas has in his talk about his key work on the sulcus and gyral key point, and I want to highlight this aspect here because this is very important for surgical planning. So one of these key sulcal and the gyral key points which has been made has been divided over the different cerebral surfaces. So the frontal-opercular key point, which is basically the workhorse of all these neurosurgery which we done from the terminal craniotomy, is based on these key points. So one of the key points is the anterior sylvan point, which is basically the area where the stem of the sylvan fissure comes out on the lateral aspect, and it is pointed by the triangular lies just behind the pterion and directly hitting on the anterior sylvan point, and from where we can start dissecting the sylvan fissure either proximally or distally. And when we go behind it, we will reach a point known as inferior Rolandic point, which is nothing but a point where the central sulcus comes down into the sylvan fissure and in some places can even hit into the sylvan fissure where the subcentral sulcus is hidden inside the sylvan fissure. So this inferior Rolandic point is actually lying at the 2 to 4 centimeter above the preauricular depression point. And this is very important point for us to understand, because this is the area where the Heschel gyrus will be lying. And so any corticotomy over the superior temporal gyrus or the middle temporal each problem in the patient. And then the other point which is important to understand is the inferior frontal and the precentral sulci meeting point. So inferior frontal sulci actually intersects with the precentral sulcus at a point which is just between the 2 centimeter area below the Stephanion craniometric point, and it actually marks the anterior border of the precentral gyrus, and also the posterior and the superior border of the orbital gyruses. So this can actually be a very important landmark when we are trying to open this area through the anatomy and all those. Now, the conclusion with the gyrus anatomy is that these sulcuses, which are forming the upper lip of the sylvan fissure, can be too varied, as Dr. Ribas did show on his talk. So we actually made mnemonic of one V. So this meaning the proximal V or the anterior V is nothing but the triangularis gyrus, and then the middle C is basically the precentral gyrus going through the subcentral side gyrus into these postcentral gyruses, and this middle U is very much evident even when you're looking at the 3D rendered the MRI scans. So one can even have an idea about that, and at the tip of it, where the central sulcus will be hitting into the sylvan fissure, will be the inferior Rolandic point. So this is a very important structure when we are trying to do, say, for example, a temporal lobectomy in a patient with epilepsy disorder. We should try to limit our lobectomy till that point, because in the dominant hemisphere, one can have a speech defect if you go a little bit more posterior to that. And then the convoluted C, which is behind the last C or the posterior C, is basically the superior marginal gyruses, and which actually covers the posterior sylvan point. So some of the studies do show that the anterior sylvan point and the posterior sylvan point, the midpoint is the IRP. So one can actually have an idea about this. So using the craniometric points over the skull, one can easily identify these gyral and the sulcal element onto the brain. The other portion is the superior portion of the cerebral hemisphere, where we can actually see the superior frontal and the central key point. So one of them is the intersection of the superior frontal and the precentral sulcus. So this is the superior frontal sulcus and then the precentral sulcus meeting point. And this is usually located 3 centimeter from the midline and 1.5 centimeter behind the coronal suture. And this point is important because it is lying over the body of the lateral ventricle, thalamus, and a little behind the foramen Monro. So coronal sulcus actually lies over the foramen of Monro in the coronal plane, but the superior frontal and precentral sulcus meeting point lies a little bit behind it. So this is one of the landmark one can use to attack the ventricular pathology from this part. Then the other important point is the superior Rolandic point, as we have already talked about in the previous slide. So this is in the interhemispheric plane where the central sulcus intersects with the interhemispheric fissure, and this superior Rolandic point actually lies 5 centimeter behind the bregma. And this is one of the important landmark when we are trying to go through the interhemispheric approaches, because when we do a corpus callosotomy at this level, the chances are that one can easily go into the subsplenial cisterns into the pineal gland. So one has to be cognizant of the fact that whenever you're doing an interhemispheric fissure, try to keep this as a landmark and try to remain in front of it when we are going through the corpus callosum, or else with is very, very high chances that we will go into the posterior. And also the hemispheric approaches, which is placed before or like anterior to this SR troubles as compared to when you go behind it, because there are a lot of venous connections behind it. Apart from that, the other key points are the parietal key points. So the number one parietal key point is the intraparietal and the post-central sulcus meeting point. So this is the intraparietal sulcus, and then this is the intraparietal and post-central sulcus meeting point. This is actually placed 6 centimeter from the bregma and 5 centimeter from the midline. And the importance is that if you go 30-degree angulation into this particular point, one can hit into the trigon or the lateral ventricle. Then the other point is the irion. So irion, as you remember, is the parietal bossing on the either side, and this is a little superior to the superior temporal line and posterior to it. And the cranial and the cerebral localization is basically it represents the superior marginal gyrus, which is separated by an angular gyrus between an intermediate sulcus, and then it is behind the or posterior to the superior temporal sulcus and the cilium fissure. So one can have an idea about the supramandibular gyrus by localizing this irion point. Then is the parieto-occipital insulae, which is basically dividing the parietal lobe from the occipital lobe. And this particular cranial localization can be made by the intersection of the sagittal suture with the lamboid suture. So this actually lies at the angle on the either side. So this parieto-occipital insulae can be identified by this landmark. Now, this is in a nutshell of these four parietal key points. So superior Rolandic point, which is 5 centimeter from the bregma, and then the parieto-occipital insulae, which is at the intersection of the sagittal suture and the lamboid sutures, and then the interparietal sulcus and the posterior central sulcus intersection point, which is 6 centimeter from the bregma and 5 centimeter from the midline, and the superior marginal gyrus or the euphoron, which is the parietal bossing or the widest area on the lateral aspect of the skull. Now we will talk about the posterior temporal key points. So in the posterior temporal key points, the most important landmark is the posterior extremity of the superior temporal sulcus, now which is identified on the cranium as lying 3 centimeter above the intersection of the squamous and the parieto-mastoid sutures. So when we go above 3 centimeter, this will be a posterior extremity of the superior temporal sulcus. Now, this is important because when we go perpendicular into the brain, we can actually go into the posterior part of the hippocampus. And then we have the occipital key points. Now, the occipital key points is basically the opistocranion, and opistocranion is the posterior or the occipital protuberance of the occiput, and which actually lies over the apex of the calcarine sulcus. And if you see the axial plane, which is made by this particular point, it will be involving the posterior part of the calcarine sulcus, the anterior part of the lingula, and then the isthmus of the cingulum, and then one can actually go into the splenium. So this particular axial plane can be defined by this opistocranium cranial landmark. So this is an important landmark from the occipital approaches point of view. Now, there are certain basal supratentorial key points, which is very important when we are trying to hit the anterior, middle, or the posterior skull basis. So it starts with the fronto-zygomatic process key point, which we also known as McCarthy's keyboard hole, as we all do it. But then there have been variation which has been there in the literature. Most people go 1 centimeter behind the pterion, but then if we go only like 1 finger breadth behind the frontozygomatic suture, or rather 5 to 7 millimeter behind and superior, we will be in a point where we can not only go towards the orbit, but can also go towards the frontal skull base, if in case we just change the direction of this particular key butthole site. Then the other butthole site or the key point site is the anterior temporal key point, which is basically just behind the sphenoid squamous suture line. If you go anterior, then we'll be going into the sphenoid bone. So it's always better to go behind, and this will be leading us to an area where the middle meningeal artery will be found. So this will actually let us open into the middle skull base. Then there's the preauricular depression key point, which is the depression which is palpable just in front of trachea. And this the anterior portion of the petrous bone. So this particular burr hole can actually lead you, a burr hole meters above it can actually lead you to the anterior portion of the petrous apex, petrous bone. And then the other key burr hole is the key point is the parieto-mastoid and the squamosal suture meeting point. So this particular burr hole, if in case made at this point, can actually lead you to the lateral aspect of the posterior part of the petrous bone. And then is the asterion, which is basically at the just behind the parieto-occipital and the intersection of the occipitomastoid sutures. And here we can actually find these the transverse sinuses as it just lifts over the over the sagittal sinus. Over the sigmoid sinus, and then we can actually have the pre-occipital notch, the plication of the dura arising at this when we are talking of the intradural association of the asterion. Now, and this is in the nutshell of all these 5 strategic burr hole positions when we are talking of the craniometric points when in relation to the skull base approaches. Now, studies have shown that if in case we follow these landmarks, we can be very much be able to identify the cortical tumor, and to less extent in places of the subcortical tumors. So in this study, they have actually studied the accuracy of the navigation when we use the craniometric point, and then they found that if they use it for the cortical lesions, then the fair chances of getting the tumor or the pathology in percent. Grade 3 are those patients where the lesion had been outside the craniotomy site. So you can see the failure rate or the chances of not getting the lesion inside the craniometry of your craniotomy is far lesser when we are using these types of localization techniques based on the craniometric points. Now, techniques have changed over the years. Initially, where people were using X-rays to identify that. Now people are using stereotactic devices. Days of pneumoencephalography and angiography have actually been gone, but then people are still using it. Some centers are actually using these types of craniometric associations based on angiographic images. And then nowadays, navigation systems are all using CT and MRI systems. So a few words about the ventricular access point, because this also uses the craniometric points to hit into the ventricle. So the most common point which we all use for external ventricular drainage is the Cocker's point, so which is nothing but a point which is 3 centimeter lateral to the midline, and it is 1 centimeter anterior to the coronal suture, or 11 centimeter from the nasion. And the trajectory is towards the mid-pupillary line, and it is pointing towards the external auditory meatus on both the sides. So when we are trying to hit by using this trajectory, the frontal horn will be hit at the 6 centimeter depth. So this is something which we all can identify the phenomenon of Monro while we're doing an EVD tap using a Cocker's point. Now, during the intraoperative exploration, when the brain is very tense because of the dilated ventricle, some of these landmarks like pains or Hunes and Park points can be very helpful to go inside the frontal horn of the ventricle and drain the CSF to relax the brain. So Payne's point is localized by a 2.5 centimeter height from the floor of the anterior cranial fossa and 2.5 centimeter behind. And this is the shortest trajectory, which is marked at 90 degrees to the cortical surface, hitting the ventricle at the depth of around 4 to 5 centimeter. However, when we go anterior, that is 2 centimeter anterior, that's a Park's point, then we will be hitting the ventricle at 5 to 6 centimeter depth. And when we go a little bit superior, that is the Hune's point, 2 centimeter above, then it will be trying to hit the frontal horn in a little bit angulation, inferior angulation, and it will be hitting at 5 to 6.5 centimeter. Now, these targeting can also be done using an ultrasound guidance, because the skull is open, and under the vision of the ultrasound, one can even hit the frontal horn very easily using these targets. Now, the other point is the Kaufman point, which is basically from the frontal approaches, which is a very short trajectory, only 7 centimeter depth to the frontal horn. So this is defined by a 0.5 centimeter above the nasion and 3 centimeter from the lateral. And what we are targeting is 3 centimeter point above the inium located at the back of the head. So one can easily target the frontal horn by using this technique. And then there's the Minosky point, which is basically a supraorbital approach to the frontal horn again. So this is targeted with an angulation of around 45 degree from the midline and 20 degrees superiorly pointed. And at the distance of 5 to 6.5 centimeter, one can hit the frontal horn again using this particular technique. And in the tubes point, which is just for the mention, because I don't think so these approaches being done these days. But this was in the past one of the favorite technique, because you don't have to use a drill. Just by using a ventricular needle, you can easily tap through the supraorbital roof. So the idea was to go 45 degree above the orbitometer line, targeting towards the midline. At the 8 centimeter, you would be hitting the frontal horn. The problem was that the orbital and the eye injuries were very common. And then since you are going through the ethmoid sinuses, some problems of the CSF rhinodia can come up later. Now, Dandy's point is one of the common points which is being used for shunt placements. And now this is 3 centimeter above and 2 centimeter lateral to the midline, and the target point is the center of the 2 centimeter above the glavula. And the Frazier point is another point which we are using, particularly in the kids. It is 6 centimeter above the inion and 3 to 4 centimeter from the sagittal plane. And then we are trying to hit the contralateral medial canthus in this target, and one can hit the ventricle and as short as 5 centimeter, the occipital horn of the lateral ventricle. So the Keynes point is used whenever we are trying to use an RMSOC or retromastoid technique or some suboccipital craniotomy technique for removing the tumor, and the patient's ventricle has to be drained and the same sitting in the same position. Then it becomes a very easy point for us to attack through. So the localization is 2.5 to 3 centimeter above the superior most part of the pinna, and then behind it. And then one can go perpendicular again to the skull, and the distance of 4 to 5 centimeter, one can easily hit the trigon of the ventricle. And then at the Sanchez point. So Sanchez point is basically targeting the temporal horn of the lateral ventricle. So this starts somewhere around 5 to 6 centimeter above the inion and 2.5 centimeter lateral. And this is a little bit angulated 5 centimeter towards the lateral aspect, and it is angulated 30 degree to the orbitomeatal plane. So in this particular angulation, one can hit the temporal horn at 9 to 10 centimeter depth. So we all have heard about the asterion. So asterion is a landmark when we are planning certain posterior fossa approaches. Even authors are talking about using auricle as one of the landmarks, where the posterior most tip of the auricle can give you an idea about the conference of the sagittal sigmoid sinus to the transverse sinus. So this posterior conference has not been marked through the bony anatomy. So this is one thing which one can use it for the surgical purposes. Beside this, craniometry is also being used for diagnostic purposes, particularly in the CBJs. So we all are aware of these atlases, particularly based on radiographs as well as on the CT scan and the MRI. So whenever to diagnose the basal invagination as well as diagnose the atlantoaxial dislocations, we actually use these craniometric points for the diagnostic reason. But I would like to keep this particular talk short in this part, because there were a lot of things which we've already discussed. So to conclude, craniometric points actually provides a validated navigation using the skull structures to the underlying cortices, venous sinuses, and the ventricular spaces. And these are very easily overlaid over the skull X-rays, angiography images, CT, and MRIs. So nowadays we can even read the MRI and CT scans and can use these craniometric points over the Garrison sulci underneath. And this can also help to plan approaches and positioning the patient before we put the patient for the advanced navigation system. So with this, I would like to end the talk, and I will be available on this email for any further clarification. I will happy to take any questions. And I would like to invite all of you this November 14 to 16 to eastern part of Nepal for a national congress. Thank you once again for your patience listening.
I want to comment, Dr. Amit. First of all, very, very nice talk, very summarized all the key points. And I'm from Brazil. I don't know Nepal actually, but I would imagine that some places will have technology and some places will not. And you can see how you can make a really nice work using all this anatomical knowledge. São Paulo is the biggest city here in South America, and we have the same two environments. We have the public hospitals that most of them will not have all this technology, and of course the private hospital that they are more equipped. But we use the craniometric points all the time. Even if we have all the technology, we are always confirming the knowledge that we have. So if you use this all the time, you will become a lot used to this. So the craniometric points are easy if you begin using them. And about the ventricular access, a lot of them are very interesting. I came from a training that we are always doing frontal approaches, just cocker points, and then later on I get into a group of neurosurgeons that I will work together, and now we are using cockers and parietal points also, but just these two. So I would see that perhaps it's best to choose one or two and to have experience, really good experience in one or two, but of course know the other ones. But I don't know if some people, it's since we have a lot of people here, it's someone using all these points, or people are really more using one or just two of them. It's interesting to see all the possibilities. But do you yourself use a lot of these points, or do you use just one of them?
Well, thank you, Eduardo, for the comments, and I definitely conjure with your remarks that craniometric points are always the first thing to be mapped on the patient's head. So even though we have navigation system in our place, which we were not using few years back, we were always using craniometric points. So even till this date, when we have a navigation system set up on the patient's head, we always start with the craniometric points placement and relationship of the pathology to these craniometric points. Now, regarding your comment to the ventricular key points, this is very valid. We do not use many of them. This all mention has been done so that people should know about the various options. So I've discussed about both the key points where the ventricle can be hit using the standard localization, and also when we open the brain and we want to localize the ventricle, because when the skull is off, the cranial pointed points are gone. So one should be aware of the Plains point or the Hughes point. So if in case somebody fails in one can actually change the local the position and can try to hit it. But as you rightly said, we should always try to stick with one method, particularly at one location, so that our chances of accuracy in subsequent surgeries are far more superior. And of course, all these points which I have mentioned, there are data in the research that the accuracy of localization in the ventricle, I think the ventricle is up to 95%. So most of these simply work. Only thing is that many of us are always tuned to some or the other than the others. So we can have more comments from the attendees on this particular aspect. This is very interesting, basically.
Also, from Dakar, Zega said they always use Coher and King's point. I think Coher is the most popular point to use for patient surgeries and DVD surgeries. And also, as you know, almost maybe more than 50% of neurosurgical centers in the world don't have navigation or other systems. Because of this, in residency education, this craniometric point is very important. In my previous hospital, with my residents, I always want them to draw the entry points and the craniotomy place. Then we check with the neuronavigation, always to educate them. I think, as Ilbas says, you can have all these kind of technologies, and nowadays we use the VR HoloLens or other device. but most of the time, the most important thing in surgical phase is the your knowledge of neuroanatomy and point, because everything can be how can I say can be broken or something can happen, but you can use your knowledge every time, and in any place you can perform surgeries with your knowledge. And I think Ribas and Thapa didn't leave any point to be discussed. Also, I didn't see any question in our
Can
chat.
I have a comment? Excuse me.
Yes,
Yes. Thank you very much,
Yeah.
Dr. Ribas, for your nice presentations. I just want to say that for young neurosurgeons and for any neurosurgeon, there should be techniques and tools which you can rely on. So when we talk about the skull and craniometric points, it's something which we can blindly rely on. And let's not forget about emergency cases. If we can have time for during the elective cases to have some all kind of navigation and the MRI, and we can evaluate all these things. During the emergency cases, we have to work fast, and I'm not only talking about the EVD, external ventricular drainage, or VP shunt. It can be any type of glioblastoma when we have patient in emergency which is deteriorating, and you should work fast. So I have been working in India for 3 years, and it was sort of rural area where we did not have a navigation all the time, especially in the night, because the ORs are different for elective and emergency, and we had to rely on our craniometric points. So it is very important. Thank you so much.
Thank you. Any comments, Ribas, Thapa, or from audience? I think there's no questions and any comments more.
Well, I just wanted to ask Ribas, because he has a very good exposure on anatomical labs, and most of the neurosurgeons who are now being trained, they feel, and actually this is always right, that they should also get some hands-on experience on the cadaveric lab. So how do you suggest to the young neurosurgeons who are in the audience to create this type of experience at their own site? So any step-by-step guidance, because you had a very good experience with the types of neurosurgical labs.
Well,
Eduardo.
when we compare the anatomical labs, they are very cheap if you compare them to other labs. So I really think that every place can have an anatomical lab, because it's really more about the people working there than about the money. If you compare to any biochemistry lab, our lab is very, very cheap. And of course, there are some regulations in some places of the world. I would imagine that Islamic countries are more difficult to have the heads, to have the brain donated. But if you are just looking for knowledge instead of doing research, just for knowing, you can have fellowships. And if you stray, I wouldn't say a month, but 3 months in a fellow, you will learn a lot. And of course, a lot of labs are more prone into research, because that's how they pay the bills. They want to show that they are producing and making researches. But I mean, the real point is to be a good neurosurgeon. So the labs need to respect that some people just want to learn. It's not really about doing articles and research. They can go just for learning. And if you stay 2 months, 3 months, you already have a lot of learning how to see the brain. And it can be during a long vacation. If you take a long vacation during your training, or just after training, you can go somewhere and just see the other people learning. You don't need to have a real research about this. Dr. Evandro's lab here in Brazil is closed now. He just passed away some years ago, and his lab closed. But he was very famous for having people just for learning. in a way, they didn't produce a lot. There was not so many papers that they could have had, and some people say this was not good for the lab itself, but I am sure it was good for the people who were there, and they became nice neurosurgeons. They learned a lot. So sometimes the lab is just for training, it's just for learning, and our main mission is to be good neurosurgeons. I would say you can be a good researcher, but to be a neurosurgeon, is the main mission, right? So
Yeah,
Abuzer,
absolutely.
yeah,
Absolutely.
try always to have people just learning. I know it's maybe it's not good for the lab, but it's good for the people.
Well, I just have a comment from Ahmed Al-Jardi, and he's asking, is there any places that offer a fellowship opportunity for young neurosurgeons or lab dissections? I know of some, but then they're not cheap. And I myself have paid a hefty amount to go and have an exposure. But then these labs, which actually gives you a plastinated models, they are the best to handle, and they give you a real sense of what the anatomy looks like. Because other cadavers, which are basically from the fresh cadavers, as they say, or the wet labs, there the brain is already like not good to handle. They're liquefied, so that doesn't make too much of sense when we're doing a white matter dissection, for that matter, or any other brain dissections. This question I believe is for Eduardo. So Eduardo, would you like to comment on this?
Well, we are trying to put a lab to establish a bigger lab here in Brazil. This year now, 2024, we organized our lab for ourselves. It's just small, but I think that I'm giving for my residents now a better exposure to neuroanatomy, to the cadavers, to see how they train with the cadavers. But it's still very small, so we can just handle one person at a time, so the residents rotate. And up to now, we could not open to invite people or fellows everywhere, but the next plan is to try to get it bigger. If you think about the world, I don't know actually places that they already organize. I know some places that do have their own lab. Dr. Abuzer now is just chief in a very nice lab in Istanbul. I know there are some other labs in Istanbul and China and USA. I would say this is the three biggest countries that will have this. But here in Brazil, we're trying to make it bigger. There is another university, the university that Dr. Ferri is already also a very known neurosurgeon here in Brazil. He has a lab too, but then it's more about courses. It's not really a fellowship that you stay there some time. But they are also trying to make it bigger. I think in 1 year or two we'll have better places here in Brazil. And I don't know about USA. Do you know, Abuzer, where in USA?
I am connecting from our lab. We have 10 fellows from around the world, from Turkey, from Sudan, from as you know, we have also we had fellows from United States, Italy, Mexico, Ecuador. You can send an email to us. Also, you can find us in social media. For international fellows, at least 1 year fellowship. You can join one year fellowship program. I think also you can find in anywhere in Europe, in United States, there are microneurosurgical laboratories. I think if you want to join this fellowship program, 1 year later you can join. I think with the, for example, we want one recommendation letter and your CV. Then your suitable schedule to join, then we can accept. I think Ahmet Al-Jardi, you can send an email also from Pittsburgh, and
I think, Dr. Abuzer, it's also important to mention what kind of fellowship guys want to take, either it's white matter dissection or particularly skull base, some drilling techniques, or is TMC neurovascular.
In our laboratory, for example, every any laboratory have their own opportunities. In our laboratory, the fellows can perform white matter dissection and also microsurgical dissection of the skull and skull base approach and the endoscopic skull base approach, and also tractography. They are learning how to do tractography. I think there are some laboratories only focused in skull base approach. Also, some laboratories only focused in the endoscopic skull base. But in our laboratory, mostly focused on the white matter dissections, but we have fellows doing a transorbital approach and endoscopic endonosal approach and some skull base approach. And also, Eduardo, do you want to say anything?
I want to say that if you join Dr. Abuzer's lab, you will make sure that you will get all knowledge. You will work hard, and usually Dr. Abuzer gives the task, titles for the topic and research, and they are being discussed every Saturday with Professor Gurture. So it's a proper fellowship work from morning till evening, which at the end of the day will give you a big exposure and experience. So we can text and Gmail Dr. Abuzer.
I gave my mail. I wrote in the chat box. I think we can close the session because we spent 1.5 hours. I want to thank all lecturers and the audience. And next week we will talk about the head and neck anatomy. Please join us. Thank you, Libas. Thank you, Thapa. Bye bye.
Thank you so much.
Thank you. Bye-bye.
I'll say hi to Dr. Ivana too. That didn't say a word, but it's nice to see you all.
Bye-bye.
And I really like your background, Eduardo.
Well, actually, this is Friday, and I'm a little bit of vacation today, but it's a pleasure to give this lecture. And I just came to the countryside of
Oh,
Brazil.
wow.
It's full
That's
of
great.
nature, so I just came.
Beautiful, wonderful.
It's a one-day vacation.
That's
It's a
completely
surgical vacation, one day.
Enjoy it. Enjoy it. Have fun.